I started doing addiction medicine about 33 years ago, coming on 34 years ago, and medical pain management for about the last 15 years. And I've been focusing on benzodiazepines for the last 5 years, an area that has been relatively neglected, but nonetheless really important. And I have really found myself to be overwhelmed by the consequences that I have heard about and now seen within the evidence-based literature. I do have some disclosures to make, mostly related to benzodiazepines. I'm a medical consultant for the Alliance for Benzodiazepine Best Practices, some work through a group called NEMA Research and the Schreiber Research Group. And I have consulted Cordon Health Solutions for drug testing and pharmacy services. I want to acknowledge right at the front end Heather Ashton, who really has been very important to all of us that are working in the field and those of us that are benzodiazepine survivors. And I want to acknowledge at the front end too, an apology to all the benzodiazepine survivors who kept courage when we weren't listening, because indeed I was part of that. And it is really important that we change the trajectory of that. And that's part of what we're doing right now, is assisting benzodiazepine survivors to be able to speak with their prescribers, and the Alliance, whose mission is to assist prescribers in particular to best prescribing practices. Kind of starts with this, right? It kind of starts with some sort of distress that results in benzodiazepine prescribing, and that's a particular challenge. We end up then with a lot of different choices that prescribers may choose from, about 14 benzodiazepines that are approved in the United States. And then, of course, the Z drugs or the Z hypnotics, or those drugs that also get attached to the GABA receptor and do some activities that are fairly similar, somewhat different, usually sleep producing as opposed to reducing anxiety for individuals. So together we call these benzodiazepine receptor agonists. They aren't all of them, but this is the primary group of benzodiazepine receptor agonists that we deal with. Let's look at some language, and that can be helpful as we go forward talking about all of this. GABA is a name that's probably familiar to most of you. Gamma-aminobutyric acid, that is a chemical that is in the brain. It's the primary chemical that does inhibition in the brain. It attaches to the GABA receptor. But it's not just GABA that works at the GABA receptor. Other chemicals also work there. And of course, that includes the benzodiazepines and the benzodiazepine receptor agonists, among which are included the Z drugs. Another abbreviation that we're going to be using here tonight, benzodiazepine withdrawal syndrome and benzodiazepine injury syndrome, which we'll be discussing to a certain extent as well. Overall, prescribing guidance really embraces this, and that is that there should be limited benzodiazepine receptor agonist initiation. There should also be limited benzodiazepine receptor agonist duration of use for most circumstances and for most individuals, 2 to 4 weeks. There may be some exceptions in that. And then safe, slow, and shared, but primarily patient-led benzodiazepine receptor agonist discontinuation processes that are involved there. Why discontinue benzodiazepines? Well, there are several reasons that we think of doing this. One, of course, is that if there is obvious loss of benefit in that particular circumstance, there's no point in continuing with it. Adverse reactions may become prominent. And then, of course, duration of use for 4 weeks or more, which I had some questions about early on as I was taking a look at that. But now I'm convinced that that should be the primary thing that we think about as prescribers when we're taking care of patients that might be on these agents. So let's walk in the shoes of prescribers, and I was one of these. We have a number of challenges that is really important for individuals that are patients of prescribers to recognize, so that we can have a conversation that is framed by an understanding of the challenges that prescribers are faced with. We were delivered erroneous received knowledge, and that primarily that knowledge was not so much from books, it is from our mentors. There's a body of so-called knowledge that we received from our attending physicians who taught us how to do medicine, that really it was erroneous, and that fundamentally was so significant that I would call it basically untrained for most of us. Another challenge is that symptoms seem unrelated to the GABA receptor function. We certainly, as physicians, are very much interested in the physiology, the neurophysiology, how things work. And when you look at the GABA receptor and our previous understanding of how that works, the issues that are brought forward by benzodiazepine survivors seem disconnected from that. And so it doesn't always make sense to us unless we dig deep and have a greater understanding about that. The symptom patterns in withdrawal seem bizarre. Alternative symptom explanations seem like they're possible or even likely for those of us that are trying to sort things out for patients. It's harder to stop than to continue benzodiazepine receptor agonists. And then, of course, there are time constraints that we as prescribers certainly have, and that significantly affects our ability to work with patients. If we have a 15 minutes visit with the patient, or even 20 or 30 minutes, far easier to write the additional benzodiazepine prescription than to address that as a primary issue, as indeed it is, because many of our office visits include a combination of things that we're trying to address. So let's look briefly at the challenge of benzodiazepine withdrawal and injury symptoms. There are at least 140 of them, and they lay out in three domains. I call them psychological symptoms, neurophysiologic symptoms, and somatic symptoms. And a lot of these just don't seem like they are connected with the GABA receptor, and so that they are unexpected. And as a matter of fact, a lot of the older studies didn't even regard some of this symptoms that would show up and consider those as being related to benzodiazepine discontinuation. And that's a problem, because that's the literature upon which a lot of us were taught, although we ourselves as students in medical school and residency and so forth weren't necessarily looking at the literature. We were receiving the knowledge from our attending physicians who were teaching us information that turned out to be inaccurate. You can find a much more complete list of symptoms, some 140 of them at our website with the Alliance. One of the challenges with regards to these symptoms is they evolve over time. When I was in medical school and early in my training, symptoms were those things, the adverse reactions were those things that showed up in the first few months. But indeed, these things can evolve over time. Depression, dyscognition, which means, cognitive, the ability to think, reason, have judgment. Dementia, probably not related to benzodiazepines. There's been a long debate about that. A recent study seems to have resulted in telling us that dementia is not related to benzodiazepine exposure, but there's still some uncertainty in relation to that. Addiction can certainly happen, but it is actually pretty rare. And there's a lot of confusion about the definition of addiction that arises in that regard. But the adverse reactions that evolve over time that really are challenging to us are those that involve what we call central sensitization. This is a process that occurs when the central nervous system is exposed to an agent. And for example, with opioids, opioids in certain individuals causes pain, not relieves pain. And the same thing seems to appear to happen in relation to benzodiazepines. So we see that anxiety can rise, and indeed, even agoraphobia. Agoraphobia is that anxiety-related condition where it's the anxiety is so severe that an individual is unable to leave the home, and that becomes quite a challenge. This was an article that first provided this information was Heather Ashton. In 1987, 50 patients that wanted to discontinue their benzodiazepines. All of them had worse anxiety on benzodiazepines, and 20% of them had agoraphobia that had not been present until benzodiazepines were provided to these patients. And all of these individuals improved subsequent to discontinuation. And then there are a variety of neurologic symptoms, and that includes pain syndromes. And then, of course, which is important and probably this audience quite aware, persistent withdrawal and even injury. The other challenge I was referring to is withdrawal symptom patterns. We're used to in medicine to understand that usually when you discontinue, say, alcohol or opioids, there's a gradual decline in severity for the withdrawal symptoms over a period of time. Not necessarily benzodiazepines, that certainly can occur, but what can happen also is that there's a decline and then there's an increase later on, an increase in severity. This is quite confusing to those of us, and we think in terms of what's the alternative diagnosis. Is there a new condition that might be showing up in relation to that? There's prolonged or protracted severity for an indeterminate period of time, but this is the one that really throws a curveball at us as clinicians. The spikes in severity overlying the other patterns. So there could be a gradual decline with spikes in severity. There could be a decline and then increase in severity. But a lot of people have really described these waves and windows, which Heather Ashton refers to. But indeed, this actually has something that was identified way back in 1982. And you can see the fluctuating symptoms in this graph by Malor and Jane back at that particular time. An important feature, but for those of us that are clinicians, a challenge to understand this. Could there be an alternative diagnosis? And of course, there always can be. There are other things that go on with all individuals, but we tend to move towards these other diagnoses rather than recognizing the relationship between benzodiazepines and benzodiazepine withdrawal and the symptoms that patients show up with. Is there an addictive need for benzodiazepines or the Z drugs? This is not particularly applicable for most individuals with benzodiazepine related challenges. Fibromyalgia or myalgic encephalomyelitis, very similar symptoms to benzodiazepine withdrawal. Chronic fatigue syndrome, early onset multiple sclerosis, Lyme disease. All of these seem to be alternatives that we might consider in individuals presenting with the kind of symptoms that show up during withdrawal. And then there's this one, somatic symptom disorder. This is a new term, relatively new term. 2013 was adopted by the Diagnostic and Statistical Manual, the Bible, so to speak, of the American Psychiatric Association in terms of making a diagnosis. A somatic symptom disorder refers to the prominence of symptoms, quite prominent symptoms, even when they're medically understood. But it goes back, has a history that has a lot to do with psychosomatic, where it implies culpability on the part of the patient. They're making it up, or they're having a psychological problem, not a physical problem. We now know that the benzodiazepine withdrawal syndrome or injury syndrome is indeed a physiologic based problem. Even with chronic pain, you could say that that's a somatic symptom disorder because of the prominence of that particular symptom for individuals that are affected. But we don't use that. I think that that is one diagnosis that needs to be reconsidered overall. And it's really important to understand that the vast majority of individuals with benzodiazepine related problems, this is related to physiologic dependence and certainly not addiction, but that confusion is really quite prominent and a particular challenge. So how do we find a prescriber in this universe where these are challenges as well? First and foremost, I believe we must find someone who listens, and someone who listens and then acknowledges. someone who listens, acknowledges, and then validates. This is the most important feature, I think, for these individuals, but then a willingness to learn, someone having skills and knowledge, and then if you're lucky enough, one who is benzo wise, somebody who has a lot of information about benzodiazepines and what to do about it. But this is the progression that prescribers go through, that I went through as I tried to figure out what was going on in the universe of individuals that are severely affected with benzodiazepines. And so we, as you know, those of you that are patients, this is it's important to understand that prescribers sit somewhere along this spectrum. Hopefully, that they're starting out with listening, but we need to recognize that arrival at benzo wise takes a while, and it took me a couple years to fully embrace the kind of things that I was hearing about and being expressed, the valid expressions, but it took me a while to say, this is a real deal. And that's going to be similar for other prescribers as well. There's a transition in the middle of all that. And in the middle of all that too, you as a benzodiazepine survivor might feel a number of things: distrusted, made to feel like a drug addict, made to feel like a criminal, punished, stupid, talked down to. There's an absence of concern or attention to your symptoms, an absence of certainly authentic listening. This is a real challenge that we face. Prescribers in the middle of that, just like any other change process that occurs, we all undergo change over a period of time. And there's this stage right here called precontemplation, where I, as a prescriber, might be totally unaware of the need for a particular change. So the activities and the discussion that occurs at this particular level are different than when somebody has made a plan and is starting to move into an action phase in terms of understanding benzodiazepines and assisting individuals in that regard. How do we have a conversation about that? So what about you and your prescriber? Most prescribers, as I mentioned, not trained adequately about the problems with benzodiazepines or even how to deprescribe. Few have trained themselves as well, and the Alliance is out there to assist them in that process. There is no really a fully reviewed list of benzo-wise prescribers. The Benzodiazepine Information Coalition maintains a list, but it's not vetted. These are individuals that have been suggested as being potentially receptive to the concerns of benzodiazepine survivors and willingness to assist them in that process. So benzodiazepine survivors, so all of us need to assist the prescriber to understand these agents. And we believe that, medical providers do have a willingness, and we hope that this is true, that the majority of them, but a lot of them, there's a number, of course, that are unwilling as well. So we need to do some sort of preparation to engage them. It's important on your part to learn about the terminology and the benzodiazepine basics. We have some information available at the website as well. Determine what your prescriber understands about benzodiazepines as well. There is at the website as well, these are kind of test questions. You can ask them what they know about benzodiazepine discontinuation, benzodiazepine side effects, and get a sense for where they are by a discussion with them as you interview the patient, as you interview the prescriber that you might be working with. And I would highly recommend that you think of that initial contact with a prescriber as an interview. You want to see how well they listen, how well they acknowledge, how well they validate, how much are they willing to learn, and what they know about benzodiazepines. So are they willing to move down that path with you? So, and then you have to be the CEO, as my wife would call it, of your own healthcare, and you want to determine what are you looking for? Are you looking for tapering guidance, or What about the symptoms? Is it symptom relief? Some individuals just want to have continuation of benzodiazepines, which we largely don't recommend, but that might be a circumstance that you're in. So positively engaging the prescriber involves asking your prescriber to be a part of your team. And I think it really is a team process. Many mindividuals, of course, are on online communities. There are peer coaching opportunities that occur out there. And there are documents within the Alliance website to assist you in that process. And the first document, I Need Your Help, will give you some ideas as to how to approach your prescriber in terms of requesting the kind of assistance that you need. And some assistance is necessary because you can't simply stop the benzodiazepine. There needs to be a trajectory and a plan established for your care. It's important to do that clearly, briefly, and respectfully. It turns out medical providers are human beings, and they have feelings too, but it's really important to frame your conversation in such a way that it will be accepted. Once your prescriber accepts your appeal, you can share additional information or the resources that are available through the Alliance website and other sources as well. You want to make sure they have the best information. A lot of our information is derived from stopping other agents like alcohol and opioids. And that's a linear description of how discontinuation occurs. You stop something, you give some medications to soften the withdrawal effect, and then slowly things get better. And we know, of course, that deprescription from benzodiazepine and their related agents, not a linear process. It's very bumpy. The FDA recognizes this. It requires different kind of training. It's more difficult for the patient and the clinician, and it takes a lot of time, takes a lot of patience, as many of you are quite aware. It requires specialized understanding about how to taper, how to address the symptoms, how to engage the support of individuals, and to assist you in terms of what's the outlook. And there really ought to be hopeful in large part, even though it takes a lot of time as well. And there are a number of tools. These tools that are available on the website with the Alliance, evidence-based, we've developed that, including a number of physicians and pharmacists and individuals that are skilled in terms of how to deliver information. We have 6 topical single-page pamphlets. There's the first one, I Need Your Help. Second one, diagnosis, and then 4 discussing deprescription and support. There's a guidance document for a discontinuation. And now new is the informed consent document as well. And we have these available for you to use. So these are the tools again. We call them pamphlets. And then here too is the informed consent. The terminology that I prefer actually is the informed choice. And the reason is consent tends to imply that somebody tells me what to do and I follow through and do it. But this is a universe where we're coming to understand that best outcomes actually occur when we share decision-making, patients and providers, in this particular process that is so challenging. So I want to invite everybody to join in the conversation, questions, but what's worked, what hasn't worked, and ideas that might be out there. I'm going to go ahead and stop my share so that I can see you folks a little bit better and answer questions that have shown up.